Radial nerve compression. It could be compressed in the area of the supinator, but there's a compression neuropathy more distal, and that's a compression neuropathy of the superficial branch of the radial nerve known as Wartenberg syndrome. Wartenberg syndrome should not be mistaken with the Wartenberg sign. The Wartenberg sign is associated with ulnar neuropathy, where there's an inability to adduct the small finger to the ring finger. This is due to paralysis of the third volar interosseous. But Wartenberg syndrome is a compression neuropathy of the superficial radial nerve. The anatomy is such that the superficial radial nerve goes between the brachioradialis and the extensor carpi radialis longus. With pronation of the forearm, there's a scissor-like action of those two tendons. Sometimes it's called handcuff neuritis. It's called handcuff neuritis because when the handcuffs are slapped on an individual's forearm, it can cause irritation of the superficial radial nerve as it's coming out between the brachioradialis and the extensor carpi radialis longus. But the differential diagnosis is very important. That of stenosing tenosynovitis of the first dorsal compartment of the wrist, de Quervain's tenosynovitis. As we see on slide number 113, around the white umbilical tape is the brachioradialis. The orange vessel loops are surrounding the superficial radial nerve. And dorsal to this, a white structure, is the extensor carpi radialis longus. We could see on the picture on the left side of slide 113, the superficial radial nerve comes right out between the brachioradialis and the extensor carpi radialis longus. If we pronate the forearm, we're going to increase the symptoms because of scissoring between those two tendons. As we go more distally, that superficial radial nerve divides, it arborizes into two or three main branches. Again, we have to differentiate this from a de Quervain's tenosynovitis. On slide number 114, we have a patient who presents with a flexion deformity of the distal phalangeal joint of the digit. This could be soft tissue or it could be bony. This is called a mallet finger, sometimes known as a baseball finger. There's a sudden flexion deformity on an extended digit that causes either a fracture of the distal phalanx, which is attached to part of the extensor mechanism, or a partial tear of the extensor mechanism itself. These are missed if x-rays are not taken. We won't know if there is a fracture fragment associated with this injury if we don't see a radiograph. And the lateral view is extremely important. This will help determine whether any surgery is required. One of the indications for surgery is a fracture fragment that's more than approximately 30% of the articular surface on the dorsal aspect. But also an indication for surgery is volar subluxation of the distal fragment, as we see on slide number 114. We lost the soft tissue support, and we need to maintain and obtain a concentric reduction of the distal phalanx. So on slide number 115, we can see the patient was taken to the operating room. This fracture was transfixed dorsally by two Kirschner wires, and then one wire went from the distal phalanx to the middle phalanx just to maintain the position of the joint while the fracture healed. Approximately 6 to 7 weeks later, we pull the wires out, but before that, we could pull the wire transfixing the joint. We can maintain the two wires in the fracture itself by starting to move the joint, and at times just applying a protective splint.